Started soon. There's just a lot of people who are joining right now, so we would just like them to have the opportunity to get online as well. Thank you for your patience. Welcome. My name is Barbara Kenner, and I'm the founder of Kenner Family Research Fund and a member of the World Pancreatic Cancer Coalition Steering Committee. I'm honored to have the opportunity to be with you today. I hope that you are all staying safe and doing well during this unprecedented time. As you know, together we represent over 95 patient advocacy groups around the world focused on pancreatic cancer. One of the most important roles the coalition plays is to connect member organizations with each other so that we can share best practices and learn from each other. Today's webinar is a great example of how, by working collaboratively and sharing insights as a result of COVID-19, we can strengthen our individual organizations so that we can better support pancreatic cancer patients in our respective countries. It's hard to believe, looking at this slide, that just a little over a year ago, we were all meeting in person in Coral Gables, Florida, for the WPCC's annual meeting. And just last month, we were due to get together in Los Angeles, California for our annual meeting. We featured several scientific panels at our meetings, and they've always received high marks and positive feedback from you. So while we can't be together in person right now, we wanted to recreate a similar panel for you virtually so that we can support each other and keep our momentum going. Before we get started, I wanted to thank the WPCC sponsors, AstraZeneca, Ipsen, Merck, Novocure, and Servier. We are so grateful for their ongoing commitment and support. Thank you. Cancer care has been dramatically impacted by the coronavirus. The pandemic is perceived to have a substantial impact on cancer outcomes, including delayed diagnosis and at times problems with suboptimal care. Accordingly, cancer diagnosis fell by approximately 40% this year. The impact of this is being felt by cancer patients and people at risk around the world, from those who have had their treatment interrupted to those worried about possible symptoms. Initial information of the novel coronavirus surfaced initially in December 2019, and in late January 2020, the World Health Organization reported that there was a new virus in China with evidence of human-to-human transmission. The disease was given a formal name in February, and 1 month later, as I'm sure everyone here remembers, COVID-19 was officially declared a pandemic. More than 36 million cases have been reported in 214 countries and territories, including more than 1 million lives lost since the first case was reported less than a year ago. The crisis is unfortunately not behind us as many countries enter winter and the flu season with outbreak of COVID-19 ongoing. Just today, we in the States were warned by scientists that this winter could be the worst time of the epidemic, with advice to get ready to hunker down. Experts globally continue to struggle with challenged health systems. Medical providers are deferring elective and preventive visits, such as annual physicals. In-person visits are being converted to telemedicine. And many patients are avoiding visits because they do not want to risk exposure. Also influencing both provider and patient behavior are the evolving recommendations restricting travel and non-essential services. The havoc caused by the COVID-19 pandemic continues to disrupt all of our daily lives, but its reach goes deeper and further with mounting consequences for cancer patients who benefit from earlier detection and treatment. A little housekeeping before I introduce today's panelists. We welcome you to ask an online question at any time by entering your question in the Q&A box. After our panelist conversation, we'll try to get to as many questions as we can. This webinar is being recorded, so you'll receive a recording within 1 week in case there's any information you missed or you'd like to share it with others. Today, we'll have a discussion with two leading pancreatic cancer clinicians about their experiences. It's my pleasure to introduce today's guest speakers, Dr. Margaret Tempero, Professor of Medicine and Director of the University of California, San Francisco Pancreas Center here in the States, and Professor Abu Hilal, who's Chair of Surgery and the Head of Hepatobiliary, Pancreatic, and Minimally Invasive Surgery at the Poliambulanza Hospital in Brescia, Italy. Did I do that okay, Mo? They're going to discuss how COVID-19 has impacted pancreatic cancer patients from diagnosis and treatment to overall clinical care. They're also going to share the role they believe patient advocacy groups like ours should be playing in our new normal. And Dr. Tempero and Professor Hilal have graciously given me permission to refer to them by their first name. So before we start, I think it would be interesting for everyone to hear from both Margaret and Mo about your institutions, just so we have a context of your experiences as we go forward. Margaret, do you want to start?
You bet. Well, first of all, Barbara, thank you for doing this, and it's an honor to be included in this. I think the more information and good information that we can get out to everyone, the easier this will all be for all of us. So I come, as you said, from the University of California, San Francisco, which is part of a huge higher education system in the state of California. At UCSF, we're the only University of California institution that doesn't have an undergraduate program. We're entirely health sciences, and we have 4 schools: medicine, dentistry, nursing, and pharmacy. We are sited all throughout the city of San Francisco, and our newest campus is at Mission Bay, just across from the ballpark where the Bay Bridge comes across into San Francisco. And that's where we take care of the pancreas cancer patients. They're all cared for at the Mission Bay site. And that's a picture of it.
And Mo?
So, good evening to everybody. I think it's good day to you in America now. So I work in the Hospital Poliambulanza Foundation Trust. It is one of the 2 big hospitals in Brescia in the north of Italy. Unfortunately, where the highest incidence of COVID-19 infection being during this year. Due to that, we had the unlucky luck of developing a huge experience of managing some 600 patients in one time in the hospital, all affected by COVID, of which 90 patients were in intensive care. And out of this time, we are a hospital of multi-specialty and second-level trauma.
Thank you. So different experiences that you have had, just given the institutions and obviously your location. Are you aware of any data that indicates that pancreatic cancer patients have an increased incidence of COVID-19?
Might be able to take that one on, Barbara. There have been a lot of studies about cancer patients and COVID in general. As you might expect, they're all observational studies, just basically looking at an experience and assembling cohorts of people and trying to compare them to subjects without cancer. And some of the more recent studies would suggest that cancer patients aren't any more susceptible to COVID than their age-related counterparts who don't have cancer. One exception might be with blood cancers. These often cause immunosuppression, so patients they don't have as healthy an immune system, and they might be more likely to acquire COVID and clearly more likely to have more serious disease. But for patients with pancreatic cancer, I don't think they have to feel that they are any more vulnerable to this virus than anybody else, and everybody's vulnerable. So that's why, everything we say is about protecting yourself and others, wearing a mask, washing your hands, keeping social distance, and staying home when you're sick.
Okay.
Yes, I fully agree with what Margaret have said. Obviously, there are the exceptions. I mean, when patients with pancreatic cancer are receiving chemotherapy, their special care need to be paid in their treatment and in their infection.
Okay. And Mo, when you when in this past earlier this year, when you had that increase in Brescia and all the patients in the ICU, did you notice that there was any, just observationally, did you notice that there was any more pancreatic cancer patients and other cancer patients?
No, not really. No, actually, we had less cancer patients in the hospital. Cancer patients are those who really observed the quarantines and self-isolated because they feared the disease more than others, having thought they are more vulnerable. So that was lucky. They were protected more.
Mm-hmm. And one thing that the coalition members are really interested in is earlier detection. And how is the pandemic affecting early detection of pancreatic cancer or detection?
Margaret, you want to go for that first?
Okay. Well, I think, as I think everybody's aware, we don't have a real strategy for early detection yet in this disease. And so I think what you might be referring to is earlier detection. So for instance, patients who, and this is a natural thing in any kind of a situation like this, if you are having symptoms, you might delay going to see your doctor longer and put up with your symptoms for a longer period of time until you just can't. You must see someone. Whereas when we aren't troubled by a pandemic, we would easily go in and see our primary care doctor, tell them what's going on, get the test done, and so on. So I am a bit afraid that we're getting later presentations of disease, and that concerns me, because I think right now seeing your doctor is pretty easy on telehealth, and with all the precautions in the hospital, I feel like I'm in the hospital right now. I feel like I am in one of the safest places you can be. We aren't, particularly we're fortunate in San Francisco where we haven't had such a problem with COVID, and we've been able to put the COVID patients in a separate small hospital that we reopened actually in this pandemic. And if patients are symptomatic, they don't go through the regular clinic. They actually go through into a protected area, which is only for patients suspected that might have a COVID infection. So I think hospitals are very, very safe. So I think that if we can all get one message out, it's to not be afraid to go in if you're having symptoms or any kind of a medical problem. Get your medical care. Don't delay it.
And Mo, do you comment on that?
Well, I think I mostly agree with Margaret. So there is no early detection, but as itself that we are implementing. But obviously, there have been a lot of patients who presented late. There have been many patients who were diagnosed already and lost contact during the pandemic. So we have seen many more patients coming with advanced disease and non-operable disease or at the borderline stage. And I think the most important thing that knowing that this disease is going to be with us for some time, that we raise awareness. And I think this is where the role of members of the Pancreatic Coalition can be, is now to work on raising awareness of the need to contact hospitals and facilitating the relation between hospitals and patients with pancreatic disease or with suspicious pancreatic disease.
Okay, so, we'll talk a little bit more about that too later when we get to what the coalition members can do. So if you would go back, Margaret, and talk a little bit more about specifically patients with pancreatic cancer, how this has affected their care. I know it might be a little bit different than what Mo's experience might be, just given the amount of the COVID virus that was in San Francisco versus in Brescia.
Well, I think we're all following, trying to follow the same precautions. And I think the way it affects care is that, you know, this adds another layer of things that you need to deal with. And I can't emphasize enough the strength I see in our patients who are dealing with so many things, COVID, social unrest, and their cancer. What they're coping with is just beyond my understanding. And I have the greatest admiration for how well they are doing. So the infection just causes additional precautions that we sometimes have to take. So for instance, obviously we do health screenings. We don't, if someone has new symptoms and they need to come in, they go to a special clinic. So they might not be seeing their usual provider if they're symptomatic. The other thing that happens is if you have to have a procedure in which, such as an endoscopy, where there are droplets of things that can get into the air, we have to ensure that the patient who's getting the procedure is COVID negative. So that's another layer where you have to come in and you have to get a test to see if you have COVID. And then if not, you can safely have your procedure. That sounds simple if you're in a sort of a simple setting, but a lot of our patients are an hour or two away, have to deal with heavy traffic, and just having to come in for an extra test adds not only stress, but a lot of inconvenience and complexities in scheduling. So, but we are working it out, and we have teams of people that are navigating our patients throughout all of this. And I can tell you from personal experience, while it's not as complicated as pancreatic cancer, my husband had to have a procedure on his nose, and it meant he had to lower his masks to have that procedure. So he had to be COVID tested, and we had to go through all these hoops, which normally we wouldn't have to do. And that was a really minor thing, but I saw how it affected what we were trying to accomplish. And I think that's magnified even more for patients with pancreatic cancer. So I think, you know, we have to really understand what patients are going through and dealing with, and you know, try to set up systems that support them. And I think our nurse navigation system is really what's doing it for us.
Mm-hmm. And Margaret, is your institution administering COVID tests or giving COVID tests only within the institution, or are they also doing home kits as well?
We would love to have a home kit, but I don't think we're confident that, on a home kit yet. So right now that we are not accepting COVID testing by any other site or what have you, it has to be at a UCSF site because we have confidence in the test that we've implemented here at UCSF.
Yeah, thank you.
That isn't the case in all places. In some areas, they will accept a COVID test done at another site.
Yeah. And Mo, how have you found that this has affected your pancreatic cancer patients?
Well, I think there have been a lot of role for the pancreatic surgeon and pancreatic clinician on guiding and driving how things would be in his hospital and his clinic. So there has been a lot of variations between different hospitals. So in our hospital, and I have to say we were lucky to be able to put a huge pressure on the management to keep a clean pathway and to keep space in theaters and in ITU for cancer patients. And the luck was that I, as the chair of the department, I deal with pancreas, so I know. So we have managed to prioritize pancreatic cancer above all others, just because biologically it is much more quick in doubling time and much more quick in becoming inoperable. And luckily we have managed to not to have a waiting list, to carry on working, and also absorb many patients from other hospitals and nearby hospitals. Now, we've been quick with that, and others has followed. Still somebody is struggling, depend which type of hospital you are working in and how much bureaucracy you have. We also implemented many ways to follow up patients, like telemedicine, like phone calls, like a 24 hours a day phone number for people who want to ask, a specialist nurse in pancreatic cancer to answer, one available doctor during the day to give answers and arrange things. And I hope others will follow this type of attitude, because we were already struggling a lot with pancreatic cancer and not being able to catch up with it. And we don't need something else to make things worse. Actually, we were hoping an improvement and not deterioration in the services.
So Mo, you've recently written the global guidelines for the reintroduction of surgery after COVID-19. Can you tell us a little bit about how those guidelines came about and what was important in those guidelines that you were developing?
Yeah, I mean, the truth that my story started in February when I written a lot, and I tweeted asking everybody to close down and governments, and one of the tweets went viral and been reshared about 100,000 times and arrived to Boris Johnson, who didn't listen. So, but just a month after that, I realized that closing down has been taken by the governments who closed down as just a complete close down. So I written another paper in British Journal of Surgery saying, hold on, we closed down, but remember we have cancer patients in general. So we need to look after that. And since then, in collaboration with some colleagues, especially one of my friends, Professor Horacio Aspon in Florida, we decided to establish the international global collaboration on COVID. And this was including about 40 experts, surgical experts, let's say, and some anesthetists from all over the world. And we decided to write down the how to restart clinical surgical practices after COVID or in phase 2. And unfortunately, the paper is not out yet, but I hope it will be in the next 2 weeks in Annals of Surgery. And that puts really a lot of guidance, very, very well thought about, of what hospitals should do, what clinicians should do, what GPs or general practitioners should do, and what patients, where's the role of patient in that.
So it's really providing more than just guidelines for surgery. It sounds like it's larger than that then.
It's not only for surgery, it's also for hospital management. It's for the how to deal with patients, how to create areas and pathways for patients where they can feel safe to come into hospital to get diagnosed and to get treated. And then if you decide to treat somebody, how you get him in, how you protect him, how you protect yourself, how you prioritize patient, how to triage them, taking in consideration the disease itself, but also COVID-19.
So if pancreatic cancer was, or pancreatic cancer surgery was previously canceled or postponed, do you feel it's safe to reschedule it now, or is that really dependent upon institution?
Well, I think pancreatic cancer, when it's operable, it just should take priority and should be operated. So I have empathy with every type of patient, going from the COVID patient to the pancreatic cancer patient, but I think there have been a misconception of the concept of triage in the first era of COVID. So people were triaging who to go to ITU are those people who may survive COVID. But if you think about it, if you are triaging in a war, you will give the bed to who can survive. And I think there are many patients who have the possibility to survive if they are operated on, more than a COVID patient. So especially those patients that if you don't operate on for a few months, then your prognosis is really very severely affected, like pancreatic cancer. So I made the argument that when you take in consideration the triage and who to decide to give bed, you need to decide that there are patients with pancreatic ductal adenocarcinoma at the borderline operability, and these should be considered in the triage. If you leave them, they die. If you operate on them, they survive, and their survival for a year or two is about 95%. So maybe they can take priority over a COVID patient who is going to ITU. So we need also to be the advocates of patients with cancer in the time when everybody is advocating for a COVID patient. So it's not a fight between patients, but we shouldn't forget this for that and this for this.
Mm-hmm. Margaret, do you have any comments on that?
You know, I really empathize with what some health systems have gone through. You know, Italy, the greater New York City area. We've been very fortunate in California because we had tremendous bed capacity and ventilator capacity, and we never really had to shut down. In the beginning, we did because we weren't sure what was going to happen. And so there were a few weeks where, you know, elective things were put off. But then it became clear that we had capacity. We could go back to being business as usual, or as usual as it can get under these times. And since then, we have not been delaying any surgeries. Pancreatic cancer patients are always high priority. So I think that for us, it has not been so bad. But I do appreciate that in some parts of the world and even in parts of the United States right now, we see serious problems in some states such as Wisconsin. So you know, you can't put down your guard on this virus, and to be as careful as you can be.
I can see that what I am saying maybe sounds a little bit strange in the context, for example, of your situation, Margaret, because you didn't reach this point. Unfortunately, we had days when we were queuing 10 clinicians, everybody trying to make the case for his patients to have that only bed available that day. And this goes from the ruptured aneurysm to the pancreatic cancer, to the colonic cancer, to the patient with severe COVID. And one only will have the bed and the rest will be canceled, and some of them would die. So we had really bad times and difficult choices to make.
Let's just switch to a little bit something different. Is what would you advise a patient to do if they start experiencing COVID-19 symptoms? And
A pancreatic patient or a patient in general?
you can tell us both, actually, because I think that would be interesting.
Go, Margaret.
Well, anybody who's symptomatic should try to be tested. That's the key to, contact tracing and understanding where the infection is spreading is really, really important. So our testing sites are usually outside, and they're usually drive-through sites or you can walk in also, but generally you're outside, minimal contact with the person getting the specimen from you. And we're right now in some of our settings, especially at UCSF, we can get the answer within a few hours. Other places, for instance, nursing homes or sites in the community may take up to a few days. And that really is an issue that needs to be changed. So we really need to have fast reporting so that we can have fast containment. But until after being tested, everybody who has symptoms should self-quarantine. And if it doesn't matter really what they're symptomatic with, they really shouldn't be going out. If you have the flu too, you shouldn't be going out and spreading it to other people. So no matter what you're infected with, you probably should be staying home. But particularly if you have suspected of having COVID, you should be very well quarantined.
If a pancreatic cancer patient is asymptomatic for COVID-19, do you advise them to get tested on a regular basis?
Oh, no. We don't think that testing asymptomatic subjects on a regular basis is very fruitful. However, if a patient has been, say, cohabitating, living with someone who was diagnosed with COVID, well, that might be a good reason to test. So there are circumstances that where you might test an asymptomatic person, extenuating circumstances, but not routinely.
Okay. And Mo, would that be the same direction that you would suggest?
Yeah, I fully agree. I mean, if somebody is symptomatic, he needs to be tested, and this is, if not for him, is for who's around him, and also to guide his behavior in the days coming on how he socialize and how he distance himself if needed. Regarding patients without symptoms, we don't test them. I mean, we have no ability to test them unless they have been in contact or something more intimate, like cohabitating, living with somebody who is positive. Patients with pancreatic cancer, I think, should be treated like any other patient. There is no specific upgrading of the caution if they have pancreatic cancer.
Mm-hmm. And what do you suggest pancreatic cancer patients do, ensure that they're staying safe but still receiving the best care? I think, Margaret, that you answered part of this earlier. Do you have anything else that you want to add to that?
Just to emphasize again, the rules are so simple, and it's been shown that if you follow the rules, you'll decrease your chance of acquiring COVID by 75% or more. So it's just so simple. Cover your face, wash your hands a lot, stay 6 feet apart, and if you're sick, stay home. And that's all we need to do. If we could just get everybody to do that, we would be able to keep this beast in check. So that's what I tell my patients. I emphasize that to them every time I see them, making sure that they're being safe and doing the right thing. And I think we all need to do that, and we need to get that message out to everybody.
Thank you. Is telemedicine recommended over in-person appointments at this time?
Well, I can tell you that for somebody who has resisted telemedicine for years, I became an expert in about 2 days. I had a crash course. I think it was a game changer for all of us to understand that we could do this, actually. It was wonderful for patients in the sense that it minimized their chance of having an exposure. They didn't have to have the stress of getting out of the house into a car, coming to see us. You know, having cancer is stressful enough, but when you add on all these other things, it really can push you over the edge. So I think there were a lot of good things about it. And so I think telehealth is actually going to be here to stay after this pandemic is over. But there are some things that aren't so good. You know, I can't hold a hand on the video, and I can't wipe away a tear on a video. And so there are times when I just can't bear it. You know, I want to see that patient. I want to be with them. So I see my new patients in person. Um, we follow good practice and we're wearing masks and such, but that's important for me, and I think the patients appreciate that. And on the follow-ups, we can do telehealth, and some of my colleagues are actually combining infusion visits with the physician visits, so that if they're making a trip in, they can see the doctor on the same day. And so we're trying really hard to do those sorts of things, just to minimize exposure and make it easier for people. And I think that in the telehealth visits themselves, they tend to be shorter than a personal visit, an in-person visit. They do tend to be shorter, so they are efficient in that regard. But I think a lot of things that would otherwise have happened if you had more time together, we're missing that. So I think it's going to be a blend in the long run, a little bit of both.
And Mo, are you using telehealth as well?
Well, yeah, I mean, I started calling for telehealth from the beginning in March because I knew this is the way forward in this pandemic. I know it is not optimal. I know you're missing a lot of things, so it's not a choice. It's something we've been forced to do and consider. And also, it's a commitment from us as health carers toward the society and toward the patient to try to reduce traffic, try to reduce human movement in the streets, especially in the time when movements in the streets was high risk. We looking forward for the days that when patients come to clinic with his family and his beloved and have a face-to-face discussion and maybe a little bit of, soft element clinical assessment rather than just a talk on the TV. The same like you would have preferred to have your meeting today live with a lot of people cheering and hugging each other and just living the moment. And we trying to compromise like we're doing now and do at least what we can do in the time being.
Yeah, yeah. So it seems from both of you, and especially struck Margaret by your line, I can't hold a hand or wipe a tear away on a video, that your approach to medicine is very holistic, and that you're looking at the whole family and Mo is, or the whole person, and Mo, as you indicate too, the whole family in a sense becomes part of being this whole patient experience.
Can I add another comment, Barbara?
Yeah.
It's kind of a unusual thing too, that during COVID, we only allow one person to come in with the patient when you do see them in person. And so one advantage of the video visit is that anybody that they want can join in. You know, there's no limit really if a lot of family members want to be involved. So, you know, there's good things and perhaps not so good things about video visits. I think in the aggregate, it's probably been, like I say, such a game changer for everybody to be able to work from home, still see your patients and care for them, albeit through video. So I'm not putting it down at all.
No, but it says that you that the medical area has been able to adapt.
Yeah.
To what's going on in the circumstances right now, and where that'll be down the road. We are not sure yet what that will turn out to be. What's happening with pancreatic cancer clinical trials right now?
Barbara, just wanted to add something uh, about this situation with patients with pancreatic cancer. Although we are focusing on people not being able to come to clinic and with their families to talk about their disease, I think the worst thing that I live in these days and with patients that I operate on with pancreatic cancer is the post-operative care, is to see patients going to theaters without having somebody to say hello or goodbye to or hold their hands in the corridor, and to see them coming to intensive care and coming to the ward and spending all this time in hospital without anybody seeing them or being able to see to talk to them except you and the nurses. This is a huge pressure that or huge responsibility that it's on our shoulders to try to compensate that very important missing element. So it doesn't stop on the pre-assessment, it goes till the discharge and even after in the follow-up.
Yeah, and all the emotional issues that go with, first of all, having pancreatic cancer, being a family member of someone with pancreatic cancer, and not being able to support them when they most need it. So that puts a lot more on both of you to be able to provide that as well. As you said, they're coming in post-op to be there for them.
Yeah.
So I'm going to go back to the question I was just about to ask is about pancreatic cancer clinical trials right now.
Well, in the beginning, we weren't sure what was going to happen, and we were really worried about our capacity as well as safety for our patients and for the providers. So we stopped accrual to most of our clinical trials for the first few weeks. But then we realized that we did have capacity, that we could start to do these things, and we've been gradually reopening. And I think we're back on pretty much business as usual in terms of our open clinical trials. There are some areas where we're still, for instance, our biorepository capacity, so saving biological specimens, they had no capacity because they were handling COVID related research. And so we had to open up more and hire more people. So there's some things where with a trial required getting a biopsy from a patient for research or extra blood samples or what have you. We had to be careful about opening up those trials or reopening those trials so that to be sure that we can have the capacity to handle those specimens.
Mm-hmm. And Mo, have been any difference in what Margaret is saying in the European area?
Well, in the European area, in February, March, everybody stopped recruiting. Everything was frozen. And April, in May, we started recruiting again in some countries. I manage a few trials which are multi-center international in Europe. And some countries continues not to recruit anything like the UK, and they are focusing on COVID research. Other countries depend on the center, and other countries are open and have never been closed. In Italy, we continue to recruit, no problems. In Holland, they opened, then they closed, and they opened, and they closed. It's going from month to month. So in general, let's say in the average, there have been a great impact on recruitment. Things are slowing down, and I hope that also this resolve, because there are a number of trials where patients need to be seen after 6 months and after 3 months. And at the moment, this can't happen. So I hope a lot of efforts wouldn't have gone for nothing.
Yeah. And what's your experience with accessing investigational experimental therapies at this point?
I think from that point, we have nearly nothing going on that. So this been affected significantly. I'm talking about surgical trials have been affected partially, but The trials where, where there is an experimental drug, an experimental study, most of these has been stopped.
Mhm.
Because also the access to come to the hospital to have the experiment, which needs you need to be tested, etc., putting patient at risk. So those are trials which been hit hard.
And Margaret?
There, I have sensed a little bit of hesitancy on the part of sponsors to open trials, to start investigator-initiated trials. For instance, when we want an investigational drug for a special a trial that we design. But I think that's changing now, and I'm seeing a shift now that there's more confidence, and I think they were also worried, could we deliver? If they gave us the drug to do a small clinical trial, could we deliver? And so I think now that we're back up and things are functioning more normally, I think that they're more willing to do that now.
I know that both of you are very involved in supporting patient advocacy organizations like the ones on today's webinar. Margaret, you sit on multiple scientific and medical advisory boards, including being the chair-elect for the Pancreatic Cancer Action Network Board. And Mo, you founded the Liver and Pancreatic Cancer Charity in Southampton, England, which has one aim: to improve patient care and work together to beat liver and pancreatic cancer. How do you perceive the role of patient advocacy groups shifting during this period of challenge? And what can we do as WPCC members to provide the support that you feel is needed?
Well, I think charities have been hit hardly also by this. From one side, this was a surprise for them. They were not used. I mean, people who work in charities were not used to handle medical emergencies in this intensity. So it took them some time to react, and that obviously affected their work. But in the same time, they couldn't even have the possibility to react because of the situation and the shutdowns, etc. It's not considered as essential worker. Charity is not an essential work like going to hospital, and it's not considered as such. The donations and the fundraising has been affected significantly, whether because there is no possibility to do it or whether the economic situation has got worse. And I think it's very important now that charities are just try to take back their leading role in going back to their main aim, which is improving care of patients with pancreatic cancer. Also, people need just to realize that at the end of the day, cancer is the enemy of the century if COVID is the enemy of 2020, 2021. So we shouldn't forget our main enemy who killed more than millions and millions of patients, much more than COVID. So the support for these charities and these organizations is essential. And from this part of the organization, they need just to start, and hopefully also some governmental support and acknowledgement in their role, which is now actually they are more than needed, because a lot of things they can be played by the charities when the government is busy in other things, and some sort of collaboration can be built for better patients' interest.
And Margaret, do you have any thoughts on that?
Sure, I would add that patient advocacy organizations have, I think, a real critical role to play in reassuring the public and the patients that they can safely get medical care. There is still reluctance, and we see this in other areas where people are delaying screening colonoscopies, for example. It's safe. It's safe to do these things, and we don't want people to put off getting a workup. So I think that the advocacy organizations can help with reassuring the public that it is safe to get your health care, your routine health care. We're seeing problems with in children where they're not getting their vaccinations. This has a whole lot of other downstream consequences that we don't want to see. So I think somehow coming together around just encouraging people to take care of themselves in all ways, not just protecting against the virus, but also maintaining their usual healthcare maintenance.
So that's a good message for us to consider as a coalition. We have a question that came in that's very interesting. What about the possibility of hospital in the home, that is administering remote chemo treatment?
I'll take a stab at that. There has been some movement on that. There are, I think everybody needs to understand that sometimes we have, with our drugs, infusion reactions that can be quite serious. And so having your infusion in an infusion center where they're prepared to take care of that is pretty important. But if you've been on certain forms of chemotherapy for a while, they're simpler, they're less likely to have an infusion reaction, you could probably have that delivered by a home health care situation. So I think that is possible, but I don't think we would ever advocate a complete shift to home care for safety reasons.
Okay. That was from Daniel, who is in Australia. And the next question I have is from Diana Dupe, who's in England. She says, thank you both. Really interesting conversation. Great to hear two different experiences. Can I ask you both, in hindsight, looking back to the first wave of COVID, what would you do differently for pancreatic cancer patients? And what are the changes that you would keep even when life all settles back to normal? Thank you.
Well, I'll start if that's okay with Mel. I feel that we didn't really make any changes. For a while, we were maybe delaying a CT scan if the patient was doing well. So there were pretty minimal changes that we made, and those are completely back to normal now. I don't think I would have changed that because we really didn't know what was going to happen with our COVID cases in the San Francisco and Greater Bay Area. So I don't think I would have changed anything, actually. And I do think the things that are going to stick is telehealth because of the convenience, the fact that other family members can get involved. And it's just going to be a different kind of a blend. Right now, it's almost 80 to 90% telehealth for medical oncology. And it's probably going to be more like a 50-50 kind of a thing going forward when we're out on the other side of this.
And Mo, looking back, what would you do differently for pancreatic cancer patients?
Well, I would not personally do anything differently, but I would call for things to be done differently by governments and local authorities. I think now that we had the experience of what happened in the first wave, the governments, local authorities, and health institutions should think about creating clean hospitals, which are cancer hospitals, where COVID patients and emergency COVID are not received, and health workers are not mixed with other health workers who deal with COVID. And these areas should be dedicated only to cancer. And other hospitals in the city should be dedicated only to COVID. In this way, patients know that they have a place to go and their treatment should continue as regular rather than having a hospital where there are COVID patients, non-COVID patients, and having the risk to get everybody infected or everybody not wanting to come to hospital because of the risk.
Okay. I have one other question here that is more on a personal level because your family backgrounds are different from each other. And so I'm wondering how you protected yourself and your family during and going to the office and your work, but mainly how was it for your family?
Well, you should take that first.
Well, I wouldn't have taken that, Margaret, because I didn't do anything clever, really. It's only God's help and protection which is doing the job here. I feel that it's really very difficult. I mean, we are in hospitals where COVID was, in every corner. And you're going home, you try to clean your hands, you try to rub your clothes outside, but you know that this is not the way to get rid of COVID or to avoid infecting yourself and infecting others, and the risks are high. So all what we do is the normal self-protection, using masks, cleaning your hands, changing your clothes when you are in hospital, and going home and try to hope that everything is fine. A lot of my colleagues who be working in intensive care and in, very high risk areas, they didn't see their families for months. And that was also another very sad thing. They would have called their kids through the phone, like patients with their families. And the situation was terrible when the epidemic was so intense. And I think this is part of the job. Like when you go to operate on a patient with HIV, you do your best to avoid being contacted, but it is part of the healthcare job.
I think one of they really, our healthcare providers are our heroes, what they've been doing and going through to get through this. And the stress on them and their families, homeschooling, all the things that they've been dealing with, and the fact, the constant risk of those working with COVID patients that they might get infected. We have staff that come from multi-generational families, so maybe an elderly set of parents are living in the same household. Some of those healthcare workers have been placed in hotels and then quarantined before they go back to be with their families. So it's been very, very hard on the provider side of the healthcare system to manage this. And all of my gratitude goes out to them for what danger they put themselves into every day.
Well, I want to thank you, Mo and Margaret, for joining us today. It's been a really, really interesting webinar. We will be sending out a link of the recording of this webinar within a week. And once again, I want to thank our sponsors, AstraZeneca, Ipsen, Merck, Novocure, and Servier. And to all of you out there, thank you so much for attending. And I'd also like to thank Jenny and Kaylee for all your work to make this possible as well. You'll also be receiving an email with a survey following today's session. If you could take a moment to share your feedback, it's really so helpful for us to improve our webinars in the future. And thank you everyone for being part of this webinar, and please stay safe and well. Thank you.
Thank you everybody. Thank you, Margaret. Thank you, Barbara and Jenny.
Thank you, Mo. Thank you, Barbara.
Thank you.